Hi, this is Brian Kim. I want to share with you this case of a patient with UGG syndrome in one eye. So this patient had cataract surgery and then Restor multifocal lens implants put in both eyes, done elsewhere. And so I inherited this patient, was following her for glaucoma. And so I noticed that one eye had a 0.6 nerve and the other was a 0.35 nerve. And the 0.6 nerve had consistent pressures of in the low 20s, and the other eye was in the teens, and the patient was on glaucoma drops. So I thought it was rather unusual that the patient was having like glaucoma asymmetrically. And then I suspected that the eye with the higher pressure had the Restor lens in the sulcus. So the question is, why did the surgeon put this Restor lens in the sulcus? And you're going to see removal and replacement of this lens using my cutting technique, bisecting it in half, and then placing the Sensar lens with my modified Yamane technique. And you're going to see why I was not able to put a new lens into the sulcus in this case. So you can see this is the eye. Again, this is not a dislocated lens. The lens looks like it's fine, but it is in the ciliary sulcus. So I go ahead and make my incisions, first on the right side and then the left side. And this is intracameral epinephrine to stabilize the pupil, and then some dispersive viscoelastic to coat the corneal endothelium. Again, when you look at the eye, you're like, it looks okay. I'm using the cannula to turn the eye around just to see if I can see the edge of the rhexis up and to the left, because you can't see it because of the pupil. So I'm like, okay, I'll get to that later. And then this is a 3mm incision. And I like to use a 3mm incision when I do my lens explantation technique. You want a little bit of a bigger incision when you cut and bisect and then remove those lens pieces. So again, I'm using the cannula and clearly the lens is in the sulcus. I get under the optic and pushing some viscoelastic in, and you can see all that viscoelastic is going straight back into the vitreous space. So the PC is wide open. And then this is a Sinski hook. I'm going to go ahead and very carefully grab the optic and then carefully tug on and pull the haptic centrally. Because it's a gummy haptic, it just bends super easy and it collapses on itself, and I'm able to tuck it and pull it into the anterior chamber. And this other one, I'm able to just dial it very carefully into the anterior chamber. Very easy to place these gummy lenses into the anterior chamber for explantation. And since there's no posterior capsule, I'm able to confidently bisect the lens using microforceps and scissors. I don't have to worry about damaging anything back there because there's nothing there. While I'm holding the lens with my left hand, I quickly transition from the scissors to another forceps, and I always go after the right side piece first, because when you go after the right side piece, you can see the haptic is pointed in such a way that it's going to collapse on itself when I pull the lens piece out. And then now you're going to grab the optic on the distal side, contralateral side, and you saw I did a twirly technique. So I go ahead and twirl the optic around using the left side microforceps. And then as I pull the optic out, the haptic is able to collapse on itself. I use a left forceps to protect the corneal endothelium. You can see this is the Maltzman, and I'm retracting the iris, and lo and behold, you have a large radialization of the anterior capsule. So there's a large anterior capsule tear and a large defect, and of course there's no posterior capsule. So this is why this surgeon put this lens in the sulcus. But again, this surgeon wanted to use a multifocal lens. A patient was paying for a premium lens surgery, but then he broke the bag, and so he put the lens in the sulcus. Not quite the way I would handle that situation, and I'm surprised the lens never dislocated, but sure enough, years later, this patient was developing an UGG syndrome problem. You always want to dry the surface of the eye when you mark first. So using the Wexel sponges, you want to dry the surface of the eye, and then using the tip of the cannula, which has been marked with ink, I go ahead and mark the limbus first on the right side and then 180 degrees apart on the left side. And using the cannula tip gives you nice and discrete marks, and I really love doing it that way. And this is a fixed caliper 2.5 and 2mm for the Yamane technique, which I get from Epsilon, and I'm going to indent radially, and this is 2.5 millimeters back, and then you mark tangentially to it, and that's 2 millimeters adjacent. And then I'm using, again, the cannula to mark those little indentation marks with the cannula tip. And then using a cotton tip, I'm turning the eye towards me, and then I'm making my contralateral limbal incision, which will be for the 25 gauge needle to externalize a leading haptic. And this is a 20 gauge Lewicky AC maintainer. It's a rather tight fit, and you actually want it to be rather tight. You might have to widen the incision a little bit, but you definitely don't want to have a loosey-goosey incision for your AC maintainer. So this is a 25 gauge needle. I've already put a syringe with BSS. You can see the water coming from the needle. And now go ahead and bend it. You don't have to bend it too far from the tip, and you want to bend it so that the bevel is facing to the right. This is the right side needle. And then I'm bending it such a way when I have it in position that the bevel is going to face towards me. This is the left side needle, and the bevel is going to face away from me when you have it in position. And this is the Sensar lens. I go ahead and place it into the cartridge. Cohesive viscoelastic has been pushed into the barrel and then also loaded onto the platform there. You want to seat the optic in, and then as you bend the wings together, the optic needs to collapse concavely. The leading haptic needs to go straight into the barrel, and the trailing haptic has to come out of the cartridge. Go ahead and place it into the injector. And you want to push it all the way in. In this case, the plunger was already advanced, so I had to pull it back and then push the cartridge all the way through. And then you can see the leading haptic sticking out of the barrel. Now you can go ahead and advance the plunger. If you don't do it that way, you might actually hit the plunger on the haptic and it might damage it. Go ahead and place the 25 gauge needle through the contralateral limbal incision, placing the injector bevel down, turning the bevel to the left. My surgical assistant is going to advance the lens, twisting. This is a twist style plunger. As the lens is coming out, the leading haptic is coming out. I'm going to align the 25 gauge needle to that haptic, and with a docking technique, just flatten the haptic on the bevel of the needle. As the lens is advanced, it goes into the needle more, and as I withdraw the needle, the haptic comes out. I take over, make sure the optic is coming out flat, and then I make sure the trailing haptic is swept to the right. Turn the AC maintainer on, and now you can see the eye is filling up nicely. And I want to make sure the optic is pushed down away from the AC maintainer, pushing some dispersive viscoelastic, again, to push the optic back and protect the cornea, and also making sure, again, that the optic is underneath the AC maintainer here. And so the AC maintainer is on, infusion is on. Grab the incision, making sure the eye is in the neutral position, and you're going to start from the first mark, tunneling 2 millimeters, and then diving down. You can see distortion of the marks, but once you actually stab it in the leading edge, you know that you're in proper position. You see there's iris prolapse. When you see iris prolapse, all you do is stop infusion. So she has stopped infusion. There's no more iris prolapse. And then I'm able to very carefully, using microforceps, gently slide the trailing haptic into the anterior chamber. Again, little by little, I'm inching in. You don't want to just shove it in, because then you're going to bend the haptic. Sliding the haptic in little by little, and then I'm going to dock the haptic on the bevel of the needle, flatten it out, and it goes in quite nicely. Disengage the syringe from the needle using a hemostat, and then laying down the needle, and then internalizing the leading haptic with microforceps and laying it into the angle. Turning on infusion now. Again, you want to turn on infusion when you're tunneling the needle through the sclera, because you need to have proper position. You're going to hold the eye in the neutral position, tunnel, 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 and then you want to dive down. Again, you can see the scleral collapse. Again, this patient obviously has had a vitrectomy. And so very important to be able to hold the eye in the neutral position, which allows you to properly tunnel the needle in the correct orientation for the final position of the lens. Grasping the haptic with the microforceps, you can see that the water is on right now. If I started to develop iris prolapse, I would stop the infusion. You see I pronated my left hand so that the needle is going to approach the haptic, dock the haptic on the bevel of the needle, carefully orienting the two together. And again, this just takes a lot of practice. When you're not used to it, it's really kind of annoying and difficult to do. But I've go ahead and fed the haptic into the needle, and I'm going to withdraw both needles just a little bit and then focus on the left side. I have my forceps ready to grasp the haptic as I withdraw the needle. And you want to withdraw towards you for the left side needle. By doing it that way, you're not causing any weird distortion and bending of the haptic. You want to do it in the proper orientation. Cauterize the tip. Do the same thing on the other side, but you're going to withdraw the needle away from you because that's the direction that the haptic came from. As the needle is withdrawn, grasp the haptic quickly and then cauterize the tip. And look here. The haptic is nice and flat on the sclera. That means I made an excellent scleral shelf and scleral tunnel. If you have the haptic pointed up to the sky, that's called the flagpole sign, and that means you have a very short tunnel or no tunnel at all, which means the optic is going to sag posteriorly, and that's what will cause a decentered or tilted lens. If that happens, a flagpole sign means you have poorly executed scleral tunnel for the haptic. I go ahead and place a tendon suture and then bury it. I always put a tendon suture in these cases. Whenever you deal with vitreous, you just never know. You don't want to have vitreous coming to your wound. And this is the vitrectomy now, doing a little bit more. Again, I haven't encountered any vitreous throughout the entire case, but go ahead and remove it just in case. Just go ahead and start it. And this is the peripheral iridectomy using the vitrector. Again, it's a low cut rate, high vacuum, low aspiration, because all you want to do is grab it and then hold it with high vacuum and then cut it. This causes nice, small, discrete surgical peripheral iridectomies with proper location. And then I'm using the vitrector in cortex mode to remove all the viscoelastic from the anterior chamber. And then I'll seal my incisions, and that will be the end of the case. So again, this is a patient who had UGG syndrome just in one eye and not the other eye. This patient had a Restor multifocal lens in both eyes. But for whatever reason, the one eye had high pressures and an enlarged cup to disc ratio. I deduced that this lens was in the sulcus based upon my examination. And I went ahead and took this lens out, and lo and behold, I was correct. The lens was in the sulcus. When I took it out, again, I bisected it using microforceps and scissors. And you saw how I was able to take out each piece in a very easy and atraumatic way, protecting the corneal endothelium. And why was this lens in the sulcus? Well, because there was a giant anterior capsule tear up and to the left on the screen, and again, a large posterior capsule defect. Of course, when you're in this situation, it's tough because the patient paid a lot of money for a multifocal lens to have good range of vision, but this patient had really a complicated capsular bag situation, unstable capsular bag, but he went ahead and put it in the sulcus. Luckily, it didn't dislocate, but it did cause UGG syndrome. So we took it out and did the Yamane technique in the way I do it with the Sensar lens, very delicate on those PMMA haptics. And this patient had 20/30 uncorrected distance and near vision with the Restor lenses. At the end of the surgery, I was able to achieve 20, 25, 20, 30-ish uncorrected vision with the Sensar lens. And for the record, I used to go with a -1-ish on my refractive target. I've started to go towards -0.5, -0.75, because I've noticed with my technique, I'm still getting fairly close to what I intend. So rather than ending up a little bit more minus or so, I've moved from -1 more towards like a -0.5. And patients have been getting good refractive results. And so anyone who's learning how to perform the Yamane technique, I do encourage you to try my technique, because by externalizing the leading haptic, it secures the lens. You don't have to worry about it falling. and then it causes the lens optic to be shifted away from you, which allows you to have better access to cannulate the right side needle with the trailing haptic. And then you can internalize the leading haptic and then do the same maneuver on the left side needle, which is away from you, which is easier because you're working, again, for the trailing haptic, it's harder because you're working kind of subincisional. It's very awkward, especially if you're not used to the maneuvers. And then you have to understand the nuances of holding the eye in the neutral position, and then when you're stabbing the sclera with the needle, you just have to make sure you have proper position and get a good tunnel. If you don't, you'll get the flagpole sign. If you have a flagpole sign, that means the haptic is pointed up, which means the optic is pointed down towards the nerve, which is going to be tilted, decentered. That's really poor technique. Don't do that, please, to the patients. Properly execute these techniques. You have to be compulsive. This is why I think this is the best way for those who are learning to do the technique, because you have to be compulsive and do it exactly how I do it. And when you execute it that way, I get very consistent results, reduced risk for complications, actually rather good refractive outcomes as well. And because I'm paying attention to that scleral shelf, I'm able to get a good lens position, and this patient did well. So I hope this was helpful to you, and I thank you for your attention.